A head bump that seems minor can require urgent assessment when you take a blood-thinning medicine. You may have no cut, no loss of consciousness, and no immediate headache. You may stand up, speak normally, and feel almost completely well. But anticoagulants can make bleeding inside the skull more likely or more serious, and symptoms of a brain injury may not appear immediately. Older adults are particularly vulnerable because head injuries can be overlooked or mistaken for problems such as fatigue, medication effects, or existing memory difficulties. Here is the first useful answer. If you take an anticoagulant and hit your head, contact an urgent medical service promptly, even when the impact seemed mild and you currently feel normal. Depending on the circumstances, you may be advised to attend an emergency department for examination and possibly a CT scan. Do not wait for severe symptoms before asking for help. Call your local emergency number immediately if you cannot stay awake, lose consciousness, develop worsening confusion, have repeated vomiting, experience a seizure, develop weakness or numbness, have difficulty speaking or walking, notice one pupil becoming larger than the other, or develop a severe or worsening headache. These can be signs of a dangerous brain injury. This video will explain why a small impact can matter, which medicines are involved, what to do during the first few minutes, how clinicians decide whether imaging is needed, and what a normal CT scan does and does not mean. Why blood thinners change the situation. The phrase blood thinner is convenient, but these medicines do not literally make the blood watery. Anticoagulants interfere with parts of the clotting process. They are prescribed to prevent harmful clots that can cause strokes, pulmonary embolism, and other serious problems. Common examples include Warfarin, Apixaban, Rivaroxaban, Dabigatran, and Pradaxa. Injected medicines such as heparin and low molecular weight heparins are also anticoagulants. Antiplatelet medicines work differently. They reduce the ability of platelets to stick together. Examples include clopidogrel, ticagrelor, and aspirin. People often call these blood thinners as well, although the risks and clinical recommendations are not identical for every medicine. NICE head injury guidance specifically includes anticoagulants and antiplatelet medicines other than aspirin taken alone when clinicians consider medication-related CT imaging. That does not mean a person taking only aspirin should dismiss a head injury. Age, symptoms, loss of consciousness, memory loss, the force of the impact, and other medical conditions may still make urgent examination or imaging necessary. The exact medicine is one part of the assessment, not the entire decision. When a blood vessel is damaged, the body normally creates a clot to limit bleeding. An anticoagulant or antiplatelet medicine reduces part of that protective response. After a head impact, bleeding may therefore continue longer or become more significant before the body brings it under control. The outside of the head can also be misleading. The scalp may look normal while bleeding is occurring inside the skull. Conversely, a dramatic scalp cut may bleed heavily without a serious brain injury. The amount of visible blood does not reliably tell us what is happening internally. This is why the correct question is not simply, how hard did I hit my head? The more useful questions are, which medicine am I taking? When was the last dose? Did I lose consciousness or forget part of the event? Am I developing neurological symptoms? Was the fall from a significant height? Did I strike another part of my body? And is there someone who can notice if my condition changes? What counts as a head injury? A head injury does not require a direct blow from a heavy object. It can happen when the forehead, side of the head or back of the skull strikes a floor, wall, cupboard, car door, or piece of furniture. It can also occur when a forceful jolt causes the head and brain to move rapidly, even if the person is unsure whether the skull directly struck anything. A concussion can result from a bump, blow, or jolt to the head, or from a hit to the body that makes the head move sharply. After 60, many head injuries occur during ordinary falls. A person may trip over a rug, lose balance while turning, slip in the bathroom, or fall while getting out of bed. The incident may not appear dramatic, but the absence of a high-speed collision does not make an anticoagulated person automatically safe. A fall should be treated more seriously when the person cannot clearly remember what happened. The loss of memory may have resulted from the head injury, but the fall could also have been caused by fainting, an abnormal heart rhythm, a sudden blood pressure drop, low blood sugar, a stroke, or another medical event. That means the assessment may need to answer two questions. Did the fall injure the brain, and why did the person fall in the first place? Call emergency services for these warning signs. Some symptoms should bypass routine calls and trigger immediate emergency help. Call your local emergency number if the injured person remains unconscious or cannot be awakened, becomes increasingly drowsy, has a seizure, develops weakness or numbness in the face, arm, or leg, has slurred speech or difficulty understanding language, develops major problems with balance, coordination, or walking, becomes increasingly confused, restless, agitated, or unlike their usual self, repeatedly vomits, develops a headache that is becoming worse or will not settle, has one pupil larger than the other, develops double vision or a major new vision problem, has clear fluid or blood coming from an ear or the nose, has bruising behind an ear or around an eye without directly injuring the eye, has a dent in the skull or an object embedded in the head, or suffered a high-energy injury, such as a serious road collision or a fall from a substantial height. Do not drive yourself if you're dizzy, confused, unusually sleepy, experiencing vision problems, or developing other concerning symptoms. Use emergency transport or have another person follow the instructions given by the urgent medical service. A person with dementia, a previous stroke, Parkinson's disease, or another neurological condition may already have difficulty with memory, speech, or movement. In that situation, the important comparison is with the person's usual condition. New confusion, a new facial droop, a new inability to walk, or an unusual change in behavior is significant even if similar problems existed before the fall. What to do immediately after the impact? First, stop and sit or lie somewhere safe. Do not quickly stand and continue walking if you feel dizzy or unsteady. A second fall could produce a more serious injury. If there is severe neck pain, weakness, numbness, or a high-energy mechanism, avoid unnecessary movement while emergency help is being arranged. A significant fall can injure the neck as well as the head. If there is a superficial scalp cut, gentle pressure with a clean cloth may help control bleeding. Do not press directly on an obvious skull depression, an embedded object, or an injury where a skull fracture is suspected. Next, identify the medication. Look at the prescription container, medication list, or anticoagulant alert card. Do not rely only on remembering that it is a little white tablet. The emergency team needs the exact name, dose, and approximate time of the last dose. NHS guidance advises people using medicines such as Apixaban or Warfarin to carry their anticoagulant alert information and show it to healthcare professionals. Also note whether the person takes more than one medicine that affects bleeding. For example, someone may take an anticoagulant plus aspirin or clopidogrel. Other medicines, including some anti-inflammatory painkillers, can also affect bleeding risk. Record the approximate time of the injury and what happened. Was there a direct impact? Was there loss of consciousness? Is there a gap in memory? Was vomiting present? Did someone witness the fall? These details can influence the assessment. Finally, contact an appropriate urgent medical service. Different countries use different pathways, but the principle is the same. A person taking an anticoagulant should obtain prompt professional advice after a head injury rather than simply watching and waiting alone. Why feeling fine does not completely reassure us. A dangerous brain bleed does not always cause immediate dramatic symptoms. Some injuries produce symptoms within minutes. Others become noticeable over several hours, and concussion symptoms can sometimes appear or be recognized days later. A person may initially seem normal, but later develop headache, confusion, unusual sleepiness, imbalance, or vomiting. Older adults can develop a subdural hematoma when veins between the brain and its outer covering are damaged. Symptoms may include worsening memory, drowsiness, headache, balance problems, weakness, speech difficulty, nausea, seizures, or behavioral changes. In some cases, the original minor injury is not clearly remembered. Older age and medicines that interfere with clotting are recognized risk factors. This does not mean that every minor bump causes delayed bleeding. Most people assessed after a mild head injury will not develop a life-threatening complication. The reason for urgent assessment is that the early appearance can be falsely reassuring, while the consequences of missing a significant bleed can be severe. It is also possible to have a concussion without visible bleeding on a CT scan. A CT scan is primarily used in this setting to identify injuries such as bleeding or a skull fracture. It is not a test that proves or disproves every concussion. That distinction becomes important later. A normal scan can be reassuring about acute bleeding, but someone may still need instructions for headache, dizziness, concentration difficulties, fatigue, or other concussion symptoms. How clinicians decide whether a CT scan is needed. The medical team will first assess consciousness, orientation, speech, strength, coordination, pupils, and other neurological signs. They will ask about loss of consciousness, amnesia, vomiting, seizure, headache, and the mechanism of injury. Age matters. Under NICE guidance, a person aged 65 or older who experienced loss of consciousness or amnesia after the injury meets an age-related criterion for CT imaging. Other urgent imaging criteria include reduced consciousness, signs of a skull fracture, seizure, a focal neurological deficit, and repeated vomiting. Medication status can also influence imaging. NICE advises clinicians to consider a CT scan within 8 hours for a person with a head injury who has no other CT indication but is taking an anticoagulant or an antiplatelet medicine other than aspirin alone. Someone presenting more than 8 hours after the injury may be considered for imaging within an hour of presentation. Guidelines and local protocols are not identical in every country. In the United States, the American College of Emergency Physicians warns that standard clinical decision tools should not be used to reliably exclude the need for CT in adults with a minor head injury who take anticoagulant or antiplatelet medication. The decision therefore requires individual clinical judgment. A CT scan is quick and can identify many clinically important forms of acute bleeding. However, imaging uses radiation and is not ordered automatically in every situation. The clinician balances the likelihood of an important injury against the risks and practical consequences of testing. Someone taking Warfarin may also have an INR blood test to assess how strongly the medicine is affecting clotting. An INR outside the intended range can influence management, but an INR result cannot replace neurological assessment or appropriate imaging. People taking direct oral anticoagulants, such as Apixaban or Rivaroxaban, do not use the INR in the same way. This is another reason to tell the team the precise medicine rather than saying only, "I take a blood thinner." Do not stop the medicine on your own. After a head injury, many people immediately wonder whether they should skip their next dose. Do not make that decision without instructions from a qualified clinician. The medicine was prescribed because there is a meaningful risk of a harmful clot. Depending on the reason for treatment, suddenly interrupting it may increase the risk of stroke, pulmonary embolism, or another serious event. Continuing it in the presence of active bleeding may also be dangerous. The correct decision depends on the medicine, the reason it was prescribed, the timing of the last dose, kidney function, scan findings, injury severity, and individual clotting risk. Emergency clinicians have access to treatments that may reverse or counteract some anticoagulants when serious bleeding is confirmed or strongly suspected. Reversal also carries potential risks and is not a home treatment. It requires a carefully judged medical decision. Do not take an extra dose because you are uncertain whether the previous tablet was taken. Do not use someone else's medicine, leftover vitamin K, or an over-the-counter product as an attempted antidote. Bring the medication packaging, alert card, and complete prescription list to the hospital whenever possible. What a normal CT scan means. A normal initial CT scan is reassuring because it means no acute intracranial bleeding was visible at the time of imaging. For adults with a minor head injury who are taking an anticoagulant or antiplatelet medicine, have returned to their usual neurological condition, and have no bleeding on the first CT, American emergency medicine guidance does not recommend routine repeat imaging or routine hospital admission solely because of the medication. Appropriate discharge instructions remain essential. This guidance reflects evidence that clinically important delayed bleeding after a normal CT is uncommon. But uncommon does not mean impossible, and the evidence does not justify ignoring new symptoms after discharge. A normal scan is also a snapshot in time. It does not guarantee that every later headache is harmless, and it does not rule out concussion. The safest approach is to follow the individual discharge plan and return promptly if danger signs develop. Hospital admission may still be needed when symptoms remain worrying, consciousness has not returned to the person's normal baseline, another injury requires treatment, safe supervision is unavailable, or the clinical team has another concern. The first 24 hours after discharge. Home observation should begin only after appropriate medical assessment and discharge. NICE recommends that a suitable adult supervise a person during the first 24 hours after a head injury. The person responsible for supervision should receive the discharge instructions as well, because the injured person may not recognize deterioration in their own condition. The observer should know the person's normal behavior and abilities. They should watch for increasing confusion, worsening headache, repeated vomiting, unusual agitation, weakness, slurred speech, walking difficulty, seizure or increasing difficulty waking the person. It is not usually necessary to force someone to remain awake continuously after they have been medically assessed and allowed home. Sleepiness can occur after a mild head injury, and sleep itself is not the danger. The concerning sign is unusual drowsiness, an inability to awaken the person normally, or a clear deterioration from the discharge condition. Follow the specific instructions given by the treating team. Avoid alcohol, sedatives, and recreational drugs unless a clinician has specifically instructed otherwise. These substances can worsen balance, increase the risk of another fall, and make neurological changes harder to recognize. Do not drive until it is safe and consistent with the advice provided. Dizziness, slowed reactions, blurred vision, and concentration problems can make driving unsafe even when the scan was normal. Avoid activities that could result in another head impact. Recovery guidance recommends easing back into normal activity gradually and reducing activity when symptoms become worse. Older adults may recover more slowly than younger adults. For headache treatment, ask the clinician or pharmacist which medicine is safe with your anticoagulant. Do not automatically add aspirin, ibuprofen, or another anti-inflammatory medicine without checking, because these can affect bleeding risk or interact with existing treatment. Symptoms that can be mild, but still need monitoring. Not every symptom after a head injury means bleeding in the brain. A mild headache, tiredness, dizziness, nausea, sensitivity to light or noise, slowed thinking, irritability, memory difficulty, and disturbed sleep can occur with concussion. Symptoms vary between people and may change during recovery. What matters is the pattern. A mild symptom that gradually improves is different from a symptom that becomes more severe, returns after improving, or appears alongside a neurological warning sign. Contact the treating clinician when symptoms are not improving as expected, interfere substantially with daily activities, or persist for several weeks. CDC guidance advises follow-up when concussion symptoms do not resolve within approximately 2 to 3 weeks, or worsen when normal activities are resumed. Seek emergency help rather than waiting for a routine appointment if a headache becomes progressively worse. Vomiting repeats, confusion develops, speech changes. One side becomes weak, a seizure occurs, or the person becomes difficult to awaken. Common mistakes. After a head injury. The first mistake is assuming there is no risk because there is no external wound. Internal bleeding can occur without a scalp cut. The second is assuming there is no brain injury because the person never lost consciousness. Loss of consciousness is important, but serious symptoms can occur without it. The third is waiting for a dramatic headache. Some people first develop confusion, imbalance, weakness, unusual behavior, or drowsiness. The fourth is going to sleep alone before receiving medical advice. The danger is not sleep itself. The danger is having no one available to notice deterioration or obtain help. The fifth is stopping the anticoagulant without instructions. That can exchange a possible bleeding risk for an avoidable clotting risk. The sixth is telling the medical team only that the person takes a blood thinner. The exact medicine, dose, and last dose time matter. The seventh is assuming that a normal CT means every later symptom can be ignored. A normal scan is reassuring, but worsening symptoms still require reassessment. The eighth is focusing only on the head and never asking why the fall happened. Repeated falls, fainting, low blood pressure, medication side effects, poor vision, muscle weakness and balance disorders may require further investigation. Preventing the next fall. Once the urgent problem has been addressed, preventing another injury becomes part of protecting independence. Ask a qualified clinician or pharmacist to review medicines that may cause dizziness, sedation, or low blood pressure. Do not stop them independently, but ask whether the combination or timing can be improved. Have vision and hearing checked when appropriate. Use prescribed glasses correctly, and keep frequently used items within easy reach. Improve lighting in hallways, bathrooms, and stairways. Remove loose rugs, electrical cords, and clutter from walking routes. Install secure handrails and grab bars where needed. Wear stable footwear rather than loose slippers. Use a properly fitted walking aid when recommended. Strength and balance exercises can reduce fall risk for many older adults, but the program should match the person's health, mobility, and previous injuries. CDC fall prevention guidance encourages older adults to discuss individual fall risks and prevention steps with their healthcare professionals. Most importantly, report falls. A fall is not always an unavoidable sign of aging. It can be a warning that vision, balance, blood pressure, medication, or the home environment needs attention. The final action checklist. If you take an anticoagulant and hit your head, remember these steps. Contact an urgent medical service promptly, even if you feel well. Call emergency services immediately for loss of consciousness, inability to wake, seizure, worsening confusion, repeated vomiting, weakness, numbness, slurred speech, major balance problems, unequal pupils, or a worsening headache. Identify the exact blood-thinning medicine, dose, and time of the last dose. Do not stop, skip, double, or reverse the medication without professional instructions. Do not remain alone after discharge. Arrange responsible supervision for at least the first 24 hours and follow the written discharge advice. Return for urgent reassessment if new symptoms appear or existing symptoms become worse, even after a normal initial CT scan. A head bump on a blood thinner does not mean that dangerous bleeding has definitely occurred. It means the threshold for obtaining medical advice should be lower. Prompt assessment is not panic. It is a practical safeguard that can identify the small number of serious injuries early, while allowing most people to return home safely with clear instructions. Understanding the warning signs helps protect more than the brain. It protects mobility, confidence, and the independence that matters so much after 60. For more evidence-first guidance on medication safety, falls and warning signs after 60, subscribe to Health Insight.